and welcome to another episode of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and it's great to be back with everyone. It's a summer edition of Lessons from the Lab. I hope everyone is having an absolutely wonderful summer. Hopefully, if you're sitting on a beach, having a nice summer vacation in the water or on a beach, or if you're hiking at a national park, or you're just sitting in your home in your air condition, hopefully this will give you something to listen to and enjoy as you're relaxing in these summer days. Maybe you're even out running and training for a marathon. As you'll see, running and training for a marathon may not be good for some of your nerves. So enjoy this episode. Welcome to another episode of Lessons from the Lab. This is our summer edition of Lessons from the Lab. I'm Devin Rubin from Mayo Clinic in Jacksonville, Florida, and it's an absolute pleasure to be hosting another episode and have an absolutely wonderful guest this time. My guest this time is Dr. Rubin Shahrizaila. She is a professor of neurology all the way across the country in Malaysia and Kuala Lumpur. She is a specialist in neuromuscular diseases, specialist particularly, I think, in ALS and inflammatory neuropathies, among other neuromuscular disorders. She's been the past secretary of the International Federation of Clinical Neurophysiology, and she is an absolute wonderful person who I always learn from every time I listen to, and it's great to have you, Tina. Welcome.
Oh, thank you so much, Devin, for this wonderful invitation and also that lovely introduction. I'm going to correct you because you said she's all the way from the other side of the country. It's the other side of the world.
The other side of the world. That's right. Yeah. That's
Because,
that's
America is one country.
yeah. That's the effect of it being 7 p.m. your time and 7 a.m. my time, and my brain's still
I
waking
know,
up.
I know. I'm just,
Yeah.
I'm just teasing you. I couldn't help that.
Yes, yes, yeah. I think I deserve being corrected a lot probably today. I
Yeah,
think
12
you
hour
win.
difference.
I think you win the award because I think you're the guest that I've had who is the farthest away when I've done a recording. I think you are the other
Yeah,
side of the world. So
I am. Yeah, yeah,
yeah,
literally.
yeah. And last time we were together, I guess on podcasts, we were trying to solve the EMG education issues of the world.
Yes, trying is the operative word.
Yeah,
We shall not give up, Devin. That is still work in progress, right?
it is. It is. It's there's a lot that we can do, I think, as we discussed in our
Yeah,
AANEM
yeah,
podcast last month. And I think we're
yeah. And
working
also,
towards
of course, Jakarta. That was when we last saw each other face to face for the
yes.
ICC. So that was
Yeah.
fun.
Yeah. Well, next time we have to find a place where we're not both traveling so far. I guess Jakarta wasn't that far for you. For
But for
me.
me, it was wonderful for me. It was
Yeah.
perfect. For once, I don't have to go to the other side of the world or deal with jet lag. So that's yeah.
Yeah.
But not for
Yeah.
you.
Well,
But I think
next
it was fun
time
for you though, right?
it was great. Yeah. It
Yeah.
was a great meeting. Those meetings are really
Yeah.
nice. Not, to see each other and see colleagues
Mm.
that we don't see very often because
Yeah,
we're all
yeah, no,
spread out.
absolutely.
So, yeah.
Yeah.
Speaking of education, do for this is a really fun time of year for me, and I don't know if it's the same for you guys in terms of trainees or education, but we have a new class of residents in July, and so they're currently going through the CNP. We have a formal CNP course at Mayo over 2 months. So this is the second week now, where they're actually starting to learn a bit of EMG, and it's always fun this time of year for me. Do you have that? Is that how it works?
Yeah, it works a little bit differently here. So I guess it doesn't really follow specific academic years. It kind of goes through what individual trainees when they come onto the training program. So it's a little bit different. Although having said that, we do have our annual neurosciences meeting next week. So in terms of congresses, then this is the kind of the time of year that we would have that. But in
Mhm.
terms of training, what we do have is that we have, it's a little bit different here because we don't have clinical nephrology as a separate special subspecialty. I don't know, I don't know whether you were aware of that. So everyone is actually a neurologist, and that's the principal appointment. And and everyone would have to have learned at least basic clinical nephrology, and that includes everything, EEG, EMG, nerve conduction studies. Those are the main ones. And then and then there will be neurologists who have maybe an interest in epilepsy, so they might do a little bit more of epilepsy. But because we don't have that critical mass in terms of staff, so most of us will have to do a lot of general neurology. So I'm still doing stroke thrombolysis call, by the way.
Right.
I'm not very good at it. Yeah, I shouldn't say that on this, but yeah, I mean, it's just because there's not enough of us, so we all kind of like
Kind of do
cover
some.
each other and make sure
Yeah.
we do that. So that's how it works here, I
Yeah.
think. Yeah.
And we're a little bit similar and we've
Hmm.
talked about this in the podcast that we don't have true
Yeah.
neurophysiologists. It's very rare here. When we do our course just for our residents,
Hmm.
they're in our third year residency. We call it a CNP course, but it
Yep.
really they learn EMG and EEG kind of mixed together for
Okay.
2 months.
Mm-hmm, mm-hmm.
And
Yeah.
it's always, it is always fun when they're starting out. I think we've all been there and, having them do the needle on each other for the first time and learn
Yeah.
to learn to do it the right way. I always joke, where it's not as painful. And if they can be real cautious with their peers, then they'll be cautious with the patient. So it's fun to see them from the ground up as they're learning.
Yeah. No, no, I agree. I agree.
Yeah.
Yeah.
And the main goal I tell them is my main goal of it is not to teach them EMG. It's to get them interested in wanting to do EMG and neuromuscular medicine in the future. I want them to see
Yes.
the light and say, this is the most fun
Yeah.
area of neurology. But
I know. I mean, one tries. Yeah, and that's for us here. I think that's as much as we can do, just to kind of make it fun and hope that they might kind of like decide to subspecialize in that.
yeah,
Yeah,
I always say
on
I
board
don't
with that.
understand why anyone would not do it because it's so much fun. But we all have our interests, and for
I
some
know,
people
I
it's
know. It's a
stroke
little
and
bit, yeah, it's a little bit tricky here because I suppose if you look at the bulk of patients in all of neurology, so maybe neuromuscular disorders does not take up the most
yeah.
of general neurology. So I guess it's again trying to, deliver that care to where it's really needed. And for stroke, epilepsy, movement disorders
Yeah.
will make the bulk of that. So I'm a little bit, much as I want them to do neuromuscular disorders, somebody has to do the others.
Yeah, right.
So if somebody
Absolutely.
else is doing it, then I don't have
And
to.
I said, right. And I made a analogy at one of our AANEM board meetings saying, it's kind of like movie genres and that some people love horror and some people love comedy. And if I love horror and you don't, you're not going to start loving horror just because I do. So,
Yeah.
you can't force someone's interest, but you can show them, I think, the
Yeah.
excitement or the interesting aspects of a certain subspecialty, and then they can
Yeah,
help them
no,
decide.
absolutely.
Yeah,
Agreed.
yeah. So
Yeah.
anyway, that's our goal. Our goal of this talk, of this discussion, is that someone listens to it and decides to go into neuromuscular medicine. You
Okay.
think we can do
We
it?
shall try. I shall try.
Okay.
I'll try and do my part.
Okay, me too. Me too. So as you I think these lessons, really the goal of this is it's an educational program through AANEM where I present a case that we had in our EMG lab and we just talk through and how you would approach it. And as I said to you at the beginning before we started recording, that what I found interesting in these is that everyone has a bit of a different approach, and to hear different approaches to a clinical problem really helps me think about how I'm performing my studies and what I'm doing. So So I'd like to present a case that we had recently in the lab and pick your brain and see how you would approach this. How's that sound?
Yeah, sounds good.
Okay. All right. I'm gonna share. Let me just share my screen here, and hopefully you can see all that. Can you see all that? See my screen?
Okay.
Okay, so because some people will be just listening by podcast, I'm gonna read the case to you, even though
Okay.
you can see it, and then I'll ask you a few questions. So the patient we saw was a 49-year-old woman who was referred to our lab and to our clinic for a question of peripheral neuropathy. That was her main clinical complaint. And basically, her symptoms started way back in 2016 when she had just completed running a marathon. And really, right after that, within the day or a couple days, she noted some cotton feeling in her feet, some tingling and burning in her feet when she had her shoes on. And it was more on the outside of the left leg, but she had some on both feet. And that basically was her main symptom. It persisted for several years. It hadn't changed a whole lot, but over the course of gradually it started more in the left leg, but then it spread to involve the right as well, but same kind of distribution. And it was mainly sensory symptoms then. And then from 20 to basically now, it progressed slowly up to her knees, and her left side was worse than the right, but both were affected. And again, this was kind of the sensory tingling, burning type of sensation. She did start noticing a bit of weakness in her feet. Left was worse than right. So she was vague about it, but felt that her legs weren't as strong when she was as active and running around as it had been. And that was basically her symptoms. She didn't have any upper extremity symptoms. She had no bowel or bladder dysfunction. She really wasn't having much pain except for the burning type of feeling in her feet. So it was really those symptoms in her legs. And she had been evaluated before coming here for another opinion. She had had two EMGs that were interpreted as showing chronic sensory axonal neuropathy. And then she had a bunch of lab tests looking for causes of neuropathy, like diabetes and things like that were all normal. And so she came with a question of an idiopathic neuropathy. And in terms of her history, she was pretty healthy, actually. She had some remote history of B12 deficiency. We didn't have the details of that. It was a long time ago. And
Mhm.
she was on B12 replacement, and apparently her levels had been fine. And then she had a remote history of cervical cancer in 2005. She was treated with chemotherapy, and that was cisplatin. And she said at that time she had some neuropathy type of symptoms. Again, 2005. But she said it was different. She had this different type of tingling in both feet, and after she discontinued the chemotherapy, the tingling went away, so it had resolved. And she did have pelvic radiation, and there was no evidence of recurrent disease that had been followed, and she was cancer free. And
Mhm.
apart from that, nothing else. No diabetes, no other systemic medical problems. She was just on some vitamins, and she had no family history of any type of neuropathy. So my first,
Okay.
so that was the information we got. And my first
Mhm.
question for you is, have you ever run a marathon?
Oh God, I absolutely hate running.
Okay. Because I was gonna say, isn't like a cotton tingly feeling probably normal after running a marathon, after running 20 miles?
Well, I would have thought that, I mean, they do say with the tight fitting shoes, right? So where you're wearing the shoes, so sometimes you probably would be, um, what do you call that? There might be some entrapment with the superficial fibula and potentially, okay, I may not run marathons, but the strappy shoes. I
Yeah.
have had tickling after wearing tight-fitting strappy heels, and that's actually the sural nerve instead of your superficial fibula. So I think, prolonged periods of time where you potentially, um, uh, impinge impingement of any sensory nerves in that kind of area of the ankle and feet, potentially you're going to be left with some kind of symptoms, but you would expect it to have resolved unless if there was some underlying illness. For instance, of course, the most common would be diabetes, the fact that she's had a previous history of having had chemotherapy, so we don't know whether or not there's some residual neuropathy. So, potentially there might be some susceptibility there. So that's the sort of thing that I was kind of like thinking of.
Hmm.
And then you mentioned about the left leg. So depending on, and I wonder whether that could be, the start of maybe again fibular neuropathy with repetitive
Hmm.
injuries. So we've certainly seen that, for instance, in individuals who are very skinny legs, and then they're sitting cross-legged, for instance. So I think there was once I had a young girl with bulimia, I think,
Hmm.
and it was after she was sitting cross-legged, wrapping up Christmas presents, and then she woke up with like a foot drop, and that
Yeah.
was clearly fibular neuropathy across the knees. So those are the sort of things that I was thinking of when you talked about completing the marathon.
Yeah. Yeah, I
So I
agree. I
don't know what
mean,
you thought. Yeah.
I think compression and thin people, my example, I don't run marathons either. I run, my goal is to run a 5K. That's my resolution this year was there's a Thanksgiving 5K that I want to be able to run and not walk. So that's not much, but when I think I've mentioned this in a previous recording that years ago when I was training for a hike, like the Inca Trail or a long
Yeah.
hike,
Mhm.
and wearing a backpack with around my hips, I developed myalgia parasitica, and I developed a lateral femoral cutaneous neuropathy just from that
Ah,
belt. And it,
yeah.
as a neuromuscular doctor, it was kind of interesting because I knew what patients felt. I would get these sort of sharp, like electrical feeling, and I would tap in that
Yeah.
area. I could map out my distribution of my lateral femoral cutaneous nerve, and it went away. It got better, but
Yeah.
yeah, I mean,
Yeah.
it's just another example of repetitive compression of some of these
Yeah. Yeah.
superficial nerves. Yeah.
And there's
So
always that fear that it doesn't go away one day, as we
yeah,
get older.
right,
One
right.
day, one day you might sleep on your arm and then you find that, oh my gosh,
I
that,
know.
that wrist drop is actually not going to get better.
Yeah. Good thing we're both young. I keep saying we're still young.
Oh
My
yeah,
nerves, everything can heal perfectly. So
yeah,
yeah, but
absolutely.
so
Anyway, right.
okay.
Yeah.
So anyway, those are good thoughts. Those are things we were thinking of.
Yeah.
So
Yeah.
what would you do next? You probably want an exam, is my guess.
Yeah. So the one in 2016, so she never actually recovered in terms of the sensory symptoms from 2016 to
No.
2020, and didn't really went did she see anybody, get any consult? Do you have neurophysiology from that time
Yeah, I
or
don't.
not?
So she did see someone, and she
Mhm.
had EMGs. So as I
Mm.
said, she had two EMGs before coming here. I don't think
Okay,
we
got
had
you.
the actual details of that, except for
Okay.
the fact that it
Hmm.
was interpreted as both of them were interpreted as showing a chronic axonal neuropathy. So that's pretty much all we have.
Okay. Yeah. And 2020, no precipitating factors, and she developed it on the right leg, similar symptoms.
Yeah, she wasn't running
Okay.
another marathon. So
Okay. Yeah.
yeah.
Okay.
So yeah, I thought when we saw this patient that's yeah, it's a kind of an unusual story. Um,
Yeah, I mean, one of the things, I mean, we can examine, and then I'll share one thought. The pelvic radiation, that was the only thing that I would just bear that in mind, because I know sometimes later on after having that radiation, you might develop problems in terms of fibrosis, depending on how intensive that radiation was.
mhm. Yeah,
So whether or not that might be a factor. But that's just, yeah.
yeah,
Let's see
just
how this
right because
case evolves.
there really aren't any other things to me that stand out in the history. The
Mm.
what about the B12 deficiency?
So the B12 deficiency, I guess first of all, why does she have B12 deficiency? That would be good to know. And also, how did she present? Was it um, things that you would think about? Of course, subacute combined degeneration of the cord would be something that sometimes may present, but because of the dissociated sensory presentation, people might mistake it rather than look at the spine. But if it was picked up fairly quickly, then one would have thought that you'd be able to address that before they develop neurological
Yeah.
complications, right? But
Yep.
something to bear in mind if you're not able to localize it peripherally, if so, of course, look at the spine
Yep.
in these sort of
Right.
cases. Yeah.
And she had been on treatment, but that doesn't mean, I think,
Yeah,
it
exactly.
doesn't
Yeah.
mean she's absorbing. If she's on oral treatment, she would have
Yeah.
pernicious
Yeah.
anemia and not be able to
Yeah.
absorb that. So, okay. So let me show you what her exam was when we saw her, and I'm gonna talk this out for those listening. Our Mayo's a little unusual in terms of the way we grade. Just so you know, the Mayo's grading scale on strength is 0 is normal. It's not the MRC scale. So 0 is normal, -4 is paralyzed. So it goes kind of 25, -1's 25% weak, -2's 50, and so forth. So that just so you don't get confused that she's weak all over. So most
Yeah.
muscles were, yeah,
I saw this in your previous, and I thought,
yeah,
yes, you have to be different, right?
we have to
Not
be
go for
different. I
everything
was
like the
Mayo
rest of the
trained, so
world.
I would stick with that. Yeah.
Okay. Anyway,
And
sorry, carry on. You were
yeah,
saying, yeah.
so what was noted mainly on her motor exam was she did have moderate weakness in her left ankle dorsiflexors
Hmm.
and toe extensors, and more severe weakness of toe flexors on the left and her
Okay.
EHL on the left.
Okay.
And then the other thing, um, which actually was not marked here, it should have been, was her knee flexion on the left here. So her hamstring was -1, so 25% weak.
Hmm.
On the right, she was actually quite strong. She had some mild weakness of her toe flexors, but that was about it.
Okay.
And then her reflexes, she had absent Achilles reflexes bilaterally, as well as
Hmm.
a nearly absent left quad reflex, but that was asymmetric. Her right was normal.
Hmm. Hmm.
And
Okay.
then the other finding on her sensor exam was she had loss of sensation to all modalities throughout the left foot, and she had some mild loss, less so on the right foot to pinprick, but her vibration position sense was normal on the right, but it was very reduced on the left. So again, asymmetric sensory
Yeah.
loss with the left being worse than the right. And I think that was pretty
Okay.
much it. There wasn't any, I don't know if you have any other questions, but there wasn't any other real
Yeah. Yeah.
notable abnormalities.
Yeah. So it is quite asymmetrical. Um, okay. And it is looking more peripheral, but it's more than just individual, it's more than just the fibular nerves. It's obviously involving in L5 S1. It's also involving the is it knee extend, the knee flexor that you said?
Flexors, yeah, sorry, that
Flexor.
wasn't marked. It
Okay,
was
so the
the
knee
flexors.
flexors
The
are
extensor were
involved.
strong, yeah.
Yeah, okay. So knee flexor is involved on the left, and also the left knee jerk was
Yeah,
also affected, right? Together with
yes,
both ankle jerks.
yeah.
Okay. Interesting. So I
So,
suppose, Carol.
so does this, just looking at this, and you kind of alluded to it, does this to you seem like a typical length dependent polyneuropathy?
Well, the asymmetry would be very odd. So I would be reluctant to say that this is your typical length-dependent polyneuropathy. So there's clearly asymmetry, that's whatever process that's happening, it's affecting the left side more so than the right. And it initiated on the left, and then now it's creeping up, affecting the right side as well. So yeah, so you're starting to think about sort of like lumbosacral kind of processes, maybe affecting the left more so, and then now something that's progressing, affecting the right without any clear precipitating factors, as far as we can tell, over that period of time. Would that
Yeah.
be, yeah.
Yeah. That's what we were kind of thinking too, that it was
Yeah.
not typical of a
Mm,
typical neuropathy. And let me throw out, I know one of the areas of your expertise, you have many, but I know one of them is inflammatory neuropathy. What
yeah.
about the good old CIDP? Would that be something that you would be thinking of here? We see a lot of people sent for CIDP that have it or don't have it, but does is that in the possibility, or do you think it would be
So
unusual?
yeah, yeah. So if we're going by CIDP, if you're looking, so of course within CIDP you've got the different types of CIDP. So for a classical type, your typical CIDP, the history and the presentation would not fit into that, because in those situations you tend to see not so you tend to see sort of upper limbs involved, very patchy because it's immune mediated upper limbs, and maybe proximal lower limbs, distal upper limbs, and more symmetry as opposed to asymmetry. But of course, within the set spectrum of CIDP, you've got those that are multifocal, you've got those that are focal, you've got, predominantly motor, predominantly sensory. So that's that whole spectrum as well. But certainly you would want to be thinking about, yeah, immune mediated as well. It's just, you would have to, the EMG that you mentioned before, one would have thought that demyelinating neuropathy may have been picked up, but it mentioned axonal neuropathy. But of
Mhm.
course, we want to do our own at this stage, I think, and then see what that shows. But in terms of the history, for me, not your classical presentation of CIDP, but keeping an open mind depending on what we find on the neurophysiology. Yeah.
Yeah, I agree. I mean, I think these are the patients that for us are often sent for a question of inflammatory multifocal neuropathy.
Yeah. Yeah.
And I think probably similar to you, we don't want to overdiagnose that and put patients on immunosuppressants if they don't have good evidence for that.
Yeah.
So,
Yeah.
yeah, yeah.
And
So,
yeah, and the other one to consider, of course, would be not within the CIDP, but also immune mediated, will be multifocal motor neuropathy, sort of like conduction block, although the sensory involvement would be very
mhm,
odd for that.
yeah.
Um, so where there's two different pathologies, one being the entrapment, because she went running and wearing tight fitting shoes, and then on top of that, but now we're making things more complicated. So let's keep things simple and
Yeah,
just
exactly.
just
Right,
see,
right.
yeah, just see
I
what we
I
get.
won't give you a case of someone who has multiple different things. How about that? Yeah.
Why
So,
not? That's what really
right.
happens in
That
their lives. That
exactly. That's the we don't patients we don't tell them you can only have one thing. So, right.
okay.
Okay. Um, so just out of curiosity now,
Yeah,
so patient shows up to our EMG lab.
yeah.
If you were doing the EMG on this or the neurophysiology on this patient, just maybe in a broad answer, what would you like? How would you approach this? Do you start with conductions first or needle, and which ones do
Yeah.
you typically do?
Okay, so this is where I think maybe our practices is a little bit different. So I have this, okay, unless you're presenting with carpal tunnel syndrome, in which, like upper limb symptoms like nerve entrapment, ulnar neuropathy, or median nerve entrapment, I my approach is actually to do a very comprehensive study.
Mhm.
So normally, and also partly also because it is a training lab, and it's important for me. I think it's important that we're familiar with doing as comprehensive um, neurophysiology as we can in terms of doing both upper limbs and both lower limbs. So this sort of case, first of all, I would approach doing nerve conduction studies, but I would do it in both upper and lower limbs. You would start off with the lower limbs because that's where the pathology is. But because it's complicated, I do feel like sometimes there have just been instances where you're missing things that you wouldn't, there could be subclinical findings in the upper limbs that you would miss if you don't do those as
Mhm.
well. So that's been my approach. And depending on what we find, then you would do targeted EMG, depending on what the
Mhm.
neurophysiology shows and where the
Okay.
pathology is. And that's the way we approach. I mean, and these days we're also including neuromuscular ultrasound in what we do as well. So
Mhm.
that will come typically after the EMG,
Mhm.
unless if it's a case of ALS, and then we might do the ultrasound first, just so that we can target the EMG better in terms of
Mhm.
looking at where the involvement is most likely. Because I don't particularly like doing the EMG multiple muscles if I can avoid it. Yeah.
Yeah. Yeah, no, I agree. I think this is one, especially a case like this, that it's going to be more extensive. And
Yeah.
in terms of, so let's stick, so in terms of the nerve conductions, when
Mm,
you say being extensive, I understand doing multiple limbs. In the
mm,
limb, let's just say the left leg, because that's where we would
mm,
start, we're the most clinically affected. Would you
mm.
typically do fibular and tibial motor and do all the sensories in the leg, or do you choose one, or do you start with one and see what it shows, and then how do you decide which conductions you're going to do
Mm.
in that leg?
So in this particular patient, what I would do is I would do both the fibula and the tibial, and then do both the sural and the superficial fibula. And I would
Okay.
do it on the other side as well, just really as a comparator,
Yeah.
because
Okay.
with the patient being their own control, so to speak. Yeah.
Would you do the
So
lateral
I will,
femoral cutaneous? Would I'm
um,
just kidding.
most
No.
of the time, no.
Yeah,
In
we
fact,
went through that.
even when we get neuralgia parasympathetica, and I'm like, are you seriously kidding me? I was
Yeah,
like, can
no,
you
we
just
want
not
to.
make a diagnosis?
Yeah. Okay.
So for neuralgia, for instance, we definitely go for the normal one first, because if I
Yeah.
don't get that one, then it's
That
like game
that we do
over.
exactly the same. That's the same thing. Yeah. Okay.
Yeah, but for the superficial fibula and the sural, those are the ones that technically you should be able to get. And in terms of more motor than that, I actually tend to go more with the EMG instead of doing femorals,
Yeah.
nerve conduction studies. That's just
Yeah.
how we do
Yeah.
it. It's also in the upper limbs. I probably do EMG rather than do musculocutaneous or
Yeah.
all the other nerves that is outside the norms. Yeah.
Yeah. You'd have to have a pretty significant loss, excuse me, of I think of axons before you see some drop in amplitude of some of those proximal motor studies. So I agree, we would,
Yeah. Yeah.
especially in this patient, apart from the
Yeah.
foot, the arm is fine. And so,
Yeah.
probably doing those and even the quads, the reflex was reduced, but the strength was normal. So I agree, the femoral
Yeah.
motor is probably not going to help, whereas the needle
Yeah.
might pick up some subtle changes. Yeah. And
Yeah.
what about F waves? Do you do those routinely or in this
Yes, we
case?
do those routinely. So the only ones that I don't find useful is your EDB, sorry, the fibula recording over EDB, because I find that that's not particularly consistent even in normals.
Hmm.
It's helpful if it's there. If it's there and you see delays in latency, then that's really helpful. But then the tibial I find would be much, much more helpful, because if you don't get those, then that would be very unusual,
Yeah.
because those are pretty pretty robust.
Yeah.
Yeah.
Okay. Good. No, I don't think we're that
You agree?
dissimilar here. I mean, I don't think I'm going to show you what we did. We'll just run through
Yeah,
some of
okay.
the conductions. And I think the important point is in general is we don't know how much we're going to need to do with conductions, and there should always be a reason for picking every nerve that we're doing. So, for
Mm,
example, I would say I wouldn't expect in this case that the conductions in the left leg will be normal, but if they were completely normal,
mm,
you had huge sensor responses. Do you need to do much on the other side? And, I think I would
mm.
agree because there's asymmetry. You don't know what's normal for that patient. So comparing,
Yeah,
but maybe if everything else looks great, you don't have to extend it too much. But
yeah.
um, yeah, but it depends. So let me show you here. Um, and we won't run through all the numbers, but on our
Mhm.
machines, the green is within our normal reference values. So
Okay.
this was the fibular motor study,
Hmm.
and so stimulating ankle and knee, and that was within normal values. The amplitude was 3.3. For us, it should be over 2. So not
Hmm.
huge, but 3. So what do you think? Does that seem not too bad for you, or is that abnormal for you?
Yeah, no, that's not bad. I mean, the only thing is, would you do below and above by any
Well, that's a
chance,
good
or
question.
not?
I think this
I just
comes up a
wondered.
lot is how would the
Yeah.
below help us here?
Okay.
To me, it's if we are worried about conduction block, but the amplitude at the ankle and knee
Yeah.
drop is only
Yeah.
11%, and there's not
Yeah.
slowing between those. So I think the
Yeah.
likelihood that we would see block or slowing focally is pretty low.
Okay. So
But
you would go straight to the knee.
yeah,
As you know, just generally that's what yeah, okay,
that's what
I
that's
see
what
what.
that's what we do. We do
Yeah.
ankle and then knee, and then the decision is do we go back below to the
Yeah,
fibular
to
head
see whether or
depending
not the
on
slowing's there. Okay, makes sense,
yeah,
makes sense.
yeah. So fibular not too bad. And
Yeah,
then
that's
here's
good.
the
Yeah.
fibular F waves.
Okay, but not F waves, fibula
Okay,
not
good.
F
Yeah.
waves.
It's a mess. So probably just muscle activity there. So
Yeah.
I always
But,
tell
and
our
again,
techs,
who knows, right? With like I said, with EDB, it's,
yeah,
you may or may not get, so I probably wouldn't really rely absolutely, not getting a response. I think I'd like to see what happens with the other
yeah.
F waves as well. Yeah.
And I think a teaching point is that you could maybe make yourself believe that there's some consistency and latency around here, but
Yeah.
I would caution people not to mark that when you have all this activity because you don't know if
Yeah.
this is just fasciculations or just poor relaxation.
Yeah.
So, yeah. Okay. So then we did a tibial motor.
Okay. Also looks good.
Yeah. And
Hmm.
tibial F waves here.
Okay. Well, I'll buy that one.
That one looks better. Yes, I'm more comfortable with that. And
Yep.
that's
And
it.
that also looks good.
Yeah.
Hmm.
Yeah. So no,
And it's
no,
persistent, right? You're
yep.
getting it in all of them, so
Yeah.
no
We do
drops
eight
there as
changes.
well.
Yep.
Latency is also within normal limits. Okay.
Yep. And then we did,
Hmm.
she's 49 years old. So we did a medial plantar
Mm-hmm.
initially. We did others too, but as a more distal kind of mixed or sensory nerve. And
Mm-hmm.
that was absent there.
Yep.
So in your lab,
And
if you
this is
do that,
on the,
this is
sorry, this
on
is
the
on the
left.
left side.
Yeah.
Yeah. Yeah.
So would you expect in a 49-year-old normally you should get a plantar, medial plantar?
Well, ideally, you should get a plantar, I suppose, but then she's somebody who goes running
Yeah.
and probably does lots of things that would cause her to to lose her plantar. So I wouldn't be too worried about that. I
Yeah.
don't think. I
Okay.
think I'd want to see something more proximal, the serals and the superficial fibula.
Okay. So there's
Mm,
the Searle. And I don't know if
okay.
you do it the same way, but we often will stimulate at 3 points. So at 7 centimeters, 14 centimeters, and 21 centimeters. But our amplitude is at 14. That's what we use to compare to
Yeah.
reference. So not
So we
not great.
usually do it, yeah, just the one time, and usually, about 10 to 14. And that's obviously very small, even for
Yeah.
the amplitude is, that's clearly
It's two.
abnormal. For somebody who's
Yeah.
49, you expect that to be, about 10 or so.
Now, if she was wearing the same type of shoes that you wear when she was running, that could get the Searle. So,
No, I don't
no,
think so. No, no,
yeah, I
no.
don't think
No,
so.
that's
Yeah.
like heels.
Yeah. Okay. So that was the left. And then
Okay.
we did do a few up in the arm. Just we didn't go
Ah,
crazy in the arm, but looking for involvement subclinically. So a median sensory, which was perfectly fine. So
okay.
antidromic with a
Uh-huh.
really high amplitude, 65.
Okay. Yeah.
And then
That's
we did,
strange. I know a lot of people do anti-dromate. So, and I don't know, maybe it's because where we train. So, just in the lab that I used to train, we do orthodromic. So our reference values are also for orthodromic. So I find it quite disconcerting when I see really high amplitudes for when I see the antidromic. But yes, that's nice to know that it's normal. Yeah,
it's
agreed.
no, yeah, it's really high. And she's youngish. And we had
Yeah,
a
so
patient yesterday. Our tech asked me to look at a waveform because someone did a lateral anabrachiocutaneous and the amplitude, I don't know if you do that conduction much,
yeah.
but the amplitude was 65 microvolts. And
Oh,
she
that's
said,
huge.
can that be real? And I said, well, it probably is real. It looked real. I said, unless the electrodes were off and we're recording directly over the median nerve, which would be a little
Yeah.
unusual for that proximally. But some people that they just have really high amplitudes. So
Yeah,
we,
I mean, the only time you see, I suppose with radial snaps, then that can go super high. But
yeah, yeah.
I'd be lucky to to battle to try and get the lateral.
I
The
know,
lateral
I know. That
feel
was
is always
that was a
challenging.
record, a record. Okay,
Yeah, agreed.
so
Okay.
so median motor looked good. The ulnar motor looked good
Hmm.
too. There was a median Martin Gruber anastomosis, which is what this is here.
Okay.
I don't want to belabor this one because I want to show you some needle, but so there was a bit of a drop between the wrist and
Yeah.
below elbow from the Martin Gruber anastomosis.
Okay. Good. I'm glad that you you cleared that before I started.
Yeah, to see the way our layout is, yeah, but the routine values, the amplitude, the conduction velocity look fine, and
Yeah.
to me that made sense because she really didn't have any arm symptoms.
Yeah. Okay. Good. Yeah.
And then we
That's
did
good.
F waves on the ulnar, which looked good. And
Okay.
then the only other conduction we did here, so we went over to the other Searle because of the asymmetry, exactly what you said to
Yeah.
compare, and that was
Yeah.
absent, actually worse on this
Okay.
side.
Hmm.
We didn't do other conductions on the other side, but I
Okay.
think to your point, I would just make the point it would not have been unreasonable and probably would have been a good idea to do it because even though the fibular and tibial motor amplitudes were within our normal limits, they could have been low for that patient. So we don't want
Yeah.
to. Would you
Yeah.
agree?
No, yeah, I do think so. And sometimes the other thing that, like you said, we have reference values, but that's just taking an average. And I find, and I don't know whether you do this, but certainly in our inflammatory neuropathies, we do tend to do serial studies, and I do find, especially when I was doing a lot in Guillain-Barré syndrome, because that was one of the areas that I was interested in. I found that the sensory potentials, although they're within normal limits, when you repeated them, you do find recovery later
Hmm.
on for that. So which means that that person's normal is actually much better than whatever you thought was normal to start with.
Yeah,
And I guess I've always learned from that actually what's normal for one person is,
yeah.
yeah.
I told our
But
residents yesterday, what, because they're going to
mm,
be practicing sensory conductions tomorrow
yeah.
on each other. I said, what you should all do is when you someone does your sensory conduction, take a picture of it, put it on your
Mm,
refrigerator so you know what's your normal in case in the
yeah.
future you have a problem, you know what's normal for you. Because we don't know
Yeah.
what our normals are. Someone has a
I
lateral
know
anabrachial of
exactly,
60.
right?
Yeah. So
Yeah. Yeah, and you know what? I think that's the other reason why I do kind of like tell my trainees and my and the lab technologists that to do a very comprehensive study on the patients because they may come later on,
Yeah.
and then we have what they what their nerve conduction studies were 2 years before, so we know what's normal in comparison.
Yeah,
Yeah.
exactly.
So that's just my kind of like, yeah, that's
Yeah.
just the way I see it, I guess. Yeah. But anyway, okay,
Okay.
so far, yeah, so far I guess we're seeing mostly sensory here, right?
Yeah.
And appears to be affecting both sides, even though clinically it's asymmetrical.
Yeah.
Yeah.
Yep. So I want to get in. I know we're coming up on an hour. Um, but I want to get into a little bit of the needle. So right now I agree. This doesn't really help a whole lot,
Yeah.
except saying the sensories are affected, which clinically they were too. But
Yeah. Yeah.
if you were doing the needle exam, how would you approach it? Would you start distally, or do you have an algorithm of what muscles you would check?
Yeah. So yes, I would start distally. So the usual ones would be in this patient, the weakness is you mentioned the dorsiflexors on the left, right? And
Yeah.
also the flexors on the left as well, and also knee flexion.
Yes.
So you'd want to be doing your tibialis anterior. You'd want to be doing probably your hamstrings if the knee flexors were involved on that particular side. And you'd want
Mhm.
to be doing probably your gastroc
Okay.
on the left side. And I don't know, I guess you might want to the asymmetry, even though there's asymmetry clinically, I do find that, you know how they say that you're not going to be weak until you've lost like 50% of your CMAP, right? So I find it sometimes useful to do the other side as well, if the patient can tolerate it, because you might
Mhm.
find you might find something on the needle, even though the patient clinically is not weak.
Yeah.
Because the way
Yeah.
she's presenting, the sensories are involved both sides. So even though one is more affected than the other, I suspect that there might be pathology on both sides,
Yeah.
except that the right side maybe is not clinically apparent as yet. So that's how I
Right.
would approach it for now. Yeah.
Yeah, I
But of course,
agree.
doing
Because
the left side first to see what you find there, and then looking to see whether you're seeing similar pattern on the other side if it's tolerated. Yeah. Would
okay.
that be what you do, Devin?
Yeah.
Sorry, I'm
Yeah. And I
asking you as well.
right.
This is
No,
interactive.
yeah,
Yeah.
absolutely. And I agree that, you can have loss of axons with
Mhm.
reinnervation, and that
Yeah.
reinnervation is going to maintain the CMAP amplitude,
Yeah. Yeah.
even though there's
Yeah.
loss of motor units. But then you put a
Yeah.
needle in, and those
Yeah.
motor unit potentials are huge. So, yeah. So here were the first three muscles that were examined: the anterior tibialis, the medial gastroc, and the vastus medialis. And there were
Hmm.
fibrillations in the gastroc, and there were 2+ long duration and high amplitude motor units in the two
Mm.
distal muscles, and a little bit less so in the vastus.
Hmm.
So why not just stop there and say, okay, the surls are gone. There's distal changes in the distal muscles on needle. This is a length dependent chronic axonal sensor motor neuropathy, because
But
that's what
it's
someone else did. Two people did.
okay. But you mentioned that it was the knee flexors that were affected, not the knee extensors, right?
Yeah,
So doing the busters is not really going to really address that. You kind of need to be doing the hamstrings, don't you?
yeah,
Need to
yeah.
be doing
No,
the biceps, the short-headed biceps, and yeah.
yeah. I think that is a key point, what you're making,
Mm.
that we have to make decisions and think based on the clinical manifestation.
Yeah.
And if
Yeah.
someone's just looking at the data and stops here, you could say, yeah, the data looks like it's a length dependent neuropathy. But
Yeah, I know.
yeah,
Yeah.
so I
And
agree.
this is actually the protocol for doing just straightforward peripheral neuropathy. This is what we would do, tibialis anterior, gastro, but if it was a straightforward somebody presenting to you with sort of like a length dependent sensory motor neuropathy clinically.
Yeah.
But like you said, going back to the clinical findings, the presentation is not
Yeah.
typical of a length dependent
Yeah.
peripheral neuropathy.
And we all,
Yeah.
yeah, and I don't ever want to stop and finish a needle EMG without having a normal muscle if possible, right? So if
Yeah.
I see these distal, always, even in
Oh, you
patients,
always go for that.
yeah, because this could be multiple radiculopathies, like you said earlier.
Yeah,
So,
yeah, no,
so
absolutely. Yeah,
yeah.
yeah.
So, okay, let me show you two other clips. So we actually went up to the gluteus maximus, and I'll show you some other
Mm-hmm.
muscles too. We
Mm-hmm.
did do the hamstring as well, but this was a clip. Hopefully the sound will play from the G max on the left. And this is at rest.
Okay.
Patient's completely relaxed.
Okay. So there appears to be CRDs or complex, would you call that complex? I mean, you're the expert when it comes to EMGs with your interactive program, but that kind of burst sounded like CRD, complex repetitive discharge. Would that be right?
Yeah, I mean, I would say this is
You
something
think?
strange. There's something
And
unusual that
then
shouldn't be there. Yeah.
and also in the background, I wonder whether there were fasciculations, that kind of like
Yep.
pop coming through,
Yeah.
and they looked complex, the actual
Yep.
units that were coming through. Would that be
Yeah, I
right? I
think
mean,
right.
I'm
So
not seeing fibrillations. I mean, I can't hear it either.
yeah, I
Fibrillations
know it's
across.
hard on. Oh, did the sound not come through? Could you
I don't know.
can
Do you
you
want to? Yeah.
can you hear that?
Yeah.
Okay.
Okay.
So what I would say, I agree mostly with you. I think that this is actually a myokimic discharge. It's
Ah.
a because it's the
Okay.
same motor unit. If just for the sake of education for people listening, these can get
Yes, please
confusing
do.
in separating them out. And so it's the same motor unit. You could see that, but
Yeah.
there's some variability in the interval here,
Yep.
which would
Yep. Yep.
not be typical of a CRD. It would be much more fixed interval there. And this fires in
Okay.
a burst and then stops and then fires in a burst again. So I think it's more of a
Ah. Okay.
myokimic discharge.
Okay. Okay.
But I agree with you. This little stuff back here, I don't know. It could be. It's hard to know because it's distant. Could be a small myokimic discharge too, but it might be a fasciculation.
So that one that we're seeing,
See
and
how
maybe
it's.
yeah,
Yeah,
that one, yeah, a bit
yeah,
far away. So I wonder
yeah.
whether that was speculation. Okay,
So we
all
we
right.
found that, and then we went to the and the motor units were a little bit long there, and then I did do the biceps long head, and this is what was recorded in the biceps. So this is at rest, and it's that marching sound of a motor
Mhm.
unit, and it's a doublet. It's hard to see that's firing
Yeah.
in this regular marching pattern.
Hmm.
So I think that's also a small myokimic
Yeah.
discharge.
Yeah. Okay.
Yeah. So that was kind of interesting. I wasn't necessarily expecting that. And then the motor units, just to show you in the biceps, this is more obvious, biceps
Mm-hmm.
femoris.
Yeah.
So very long duration, high amplitude
Yeah. Long
polyphasic.
duration, quite
Yeah,
large. Yeah. It's very
yeah.
neurogenic. Okay.
And then the last thing is I went over to the other side and checked the biceps femoris, which was not weak. And this is a little harder to see, but there's these bursts in that muscle too, right there,
Yeah.
right there. You can see down here.
Yeah.
kind of distant, but there's these distant myokimic discharges there too.
Yeah, yeah.
So, that's interesting, right?
So you see, I knew that pelvic radiation thing was something.
Yeah, I know. You pinpointed that.
Yeah, but do you know what? Only because I'm not going to tell you this because one day I'm going to get you on my side and pick your brains. And actually, we had a very interesting case. And to me, never discount radiation that was done in the past.
Yeah.
And what you're demonstrating here is, are we right?
Yeah, I think I agree. I mean, I think with this finding, and you could see there were neurogenic changes kind of throughout the
Yeah,
muscles,
on the
even the
other side.
paraspinals. But I think
Yep,
that
yeah,
the myokimic discharges were key. That
yeah,
I think this was the radiation-induced problem involving the roots or the roots in the plexus.
yeah.
Yeah,
Because presumably because at that stage they were not as targeted in terms of the radiation, and I think there was a lot. Sometimes there can be a lot more damage that isn't apparent, but usually about 20 years down the line, you start seeing all of these changes in the
yeah,
muscles that are
yeah.
involved. That
And
are,
patients have
yeah,
a hard time understanding that. I think whenever we tell
yeah,
them this is radiation, they say, "How in the world can you say that that was in 2005?" But
yeah. I
we all
know.
know it does happen. It's a delayed
It
effect.
does. No, absolutely. Yeah, yeah.
Let me ask you one other question. If you had only seen a myokimic discharge in just one muscle, let's say the gastroc, and that was
Yeah.
it, would that be enough in this case with all the other findings? Would that have still made you think it was radiation?
Well, the thing is, you would put it in your differential diagnosis, and so the idea is to exclude other possibilities, right? So you talked about inflammatory neuropathies. Obviously, that's not what's happening here, given that the F waves were pretty normal. So there's nothing, not even proximal demyelinating features. So what I would do is probably see the patient again
Mhm.
and repeat some of these studies because you can only do so much with the needle. The muscle is huge. I mean, you're just sampling small areas. You're not
Mhm.
going to be getting, you can't sample the entire muscle. It doesn't mean that it doesn't take you away from the potential
Yeah.
differential diagnosis given the presentation and the findings.
Yep.
Because there's the comfort level as well. You can't just treat the patient as a pincushion and just
Yeah.
just to try and make your point. But I
Yeah,
guess
and
that's the way I would approach it. Yeah.
I agree. I mean, I think the point I wanted to make, and we published, I'm not going to go through this in detail, but we looked at our series of
Oh,
patients with
there you go.
myokimic discharges in the EMG lab, and we had a group
Mm,
of patients that had radiation. I think 35 patients with radiation and 35 that did not have any history of radiation. And you can see a myokimic discharge in all sorts of conditions. It's not just radiation. So radix and neuropathy, we saw some, but most of these patients that they only had it in one muscle. It was an isolated single myokimic discharge, whereas
yeah.
the patients with radiation usually had it in multiple muscles. So I think the
Mhm.
point here is like in this case that if having it in three different muscles in the context of radiation, I think it's
Yeah.
pretty much a slam dunk. This is the cause.
Yeah. Yeah.
But if
Yeah.
it was just one muscle and I found one discharge, then I wouldn't know. I think like you, I'd say it probably is still the radiation, but
Yeah.
make sure there isn't something else going on.
Yeah. Because one of the other things, I suppose, is because your differential diagnosis, if you're going to go down the degenerative process, then that's got a different trajectory and prognosis. So you kind of want to be searching for something that has got a better,
Yeah, yeah,
that's got a
exactly.
more,
Because there isn't
yeah,
any
you
treatment
know,
for this.
yeah,
Yeah,
exactly.
yeah. So
So one would want to be cautious, especially when you've got that radiation history. But yeah.
right. Well,
But
that
anyway, I learned a lot. You are fantastic at EMGs, and
uh,
I would listen to that. I was like, oh my gosh, that sounds like.
no, I think this is great, and I mean, I wanted to present this case to you because I learned a lot from you in in the discussion, but it just was an unusual way this presented, and
Yeah,
the marathon running was probably a red herring, and maybe there was a little
hmm,
entrapment or compression of some of the
yeah,
sensor
yeah,
nerves, but we see lots of patients, I'm sure you do, where it's coincidental. Something happens that's just
yeah,
completely coincidental, but they say
yeah,
this is what caused my problem. So,
yeah, yeah.
yeah.
I know. So that's really funny because I guess I know your modus operandi. When you showed the pelvic radiation, I was like, I'll bet you this has got something to do with it.
Yeah.
Plus the
Well,
fact that I have had a similar patient, and for the longest time, so they were referred for motor neuron disease because that's what they're going to present with, right? Start with one limb, and that's typical of presentation of ALS. But if you don't pick up that past history of radiation 20 odd years ago, you're going to be going down the route of ALS.
yeah,
And that is exactly what happened to the case that I was alluding to. And that is why now, my radar when it comes to radiation is like, let's just have a look and see. And then you then pinpoint to the areas and then just see whether it's feasible. Yeah.
yeah. And I
And
think,
like, and you demonstrated as well, it's not just even if the other side is not affected, you really do have to go to the other side,
yeah,
the right side, and you found similar myoclonic
right.
changes there as well. So
And
yeah.
I think the thing we're both saying, and we both know from our experience, is that with
Yeah.
all the fancy testing we have and all the
Yeah.
decisions of which nerves to do, it comes down to the history and the exam. And if you don't take a
Yeah.
good history as here, as you're saying, you're not going to
Yeah.
think about radiation. And if you don't do a good exam, it could be
Yeah.
very easy for someone to just do the data and say this is just a neuropathy, and it's clearly
Yeah.
not a typical neuropathy. So
Yeah.
these
Yeah.
are basic points, but they're so important for, especially for those listening that are younger, that are newer to this.
Yeah.
You have to take a good history and exam before you're making your EMG decisions. So,
Yeah.
well, I really appreciate you taking an hour of your evening. My day's just starting, but this is going to be the highlight of the day, I think. It's always nice seeing you and talking with you and learning from you, and I
Yeah.
really appreciate you taking the time to do this.
Yeah, no, thank you so much, Devin. I'm truly honored to be invited, and also, just learning from you. You are complete master when it comes to EMG, especially, and it's really nice to be able to talk through these because these are your atypical cases, right? The ones that we see and we learn from over the years. And for me, it's usually, I don't know about you, but I learn from my mistakes, and that's the ones that I share.
Hmm.
As opposed to the slam dunk ones, it's like, who wants to know about those?
Yeah,
So
right.
yeah.
Yeah,
So
yeah.
anyway, thanks
Well,
again for the opportunity. Lovely to see you.
you too, and I hope you have a wonderful evening, and I can't wait to see you again soon.
Yeah, you too.
All right.
Hopefully, yeah, hopefully soon.
Yes. All right. You take care. Thank
All
you
right.
again. I hope you enjoy this episode of this very interesting patient with an interesting neuromuscular condition. I certainly learned a lot from Dr. Shahrizaila. I always do. It's a wonderful discussion. And as I always say, it's interesting and instructive to hear the variations in how we all approach a patient. There are certainly variations, but there are also quite a bit of similarities in how we come to a conclusion. And this was an unusual patient that presented in an unusual way and had an unusual neuromuscular disorder, something we don't see very often. And I think, as we said at the end of the discussion, that there's a really instructive point on this case, and that's the importance of taking a thorough and accurate history and the importance of doing a very careful neuromuscular examination and knowing the findings that are atypical for the typical things that we see. So in this case, the findings were not typical clinically for a length-dependent symmetric neuropathy, and that should be a clue and ring a bell that I need to think about some other localization, and I may need to do different testing on my nerve conductions or on my needle examination to come to the accurate conclusion. I think another instructive point is being really observant on some of the needle EMG waveforms. Sometimes these abnormalities, such as myochymic discharges, can be subtle. They're small, they're not obvious, they're firing slowly, and may be overlooked at times. So you have to pay attention, particularly in the context of a patient who has had radiation and perhaps has some radiation-induced nerve damage. So hopefully you've taken those points home with you, and that will help you in your practice. And even though this patient presented after running a marathon, I would say it's probably important to exercise. And maybe someday I'll see you out on the running course or the marathon course, as we're both keeping our exercise up in the future. Bye bye.